Generally speaking, we have shifted pretty dramatically towards preferring using preoperative therapy for our patients with HER2 positive disease. The reason is that this allows us to assess response to therapy and then potentially adapt our adjuvant treatment after surgery based on this response. And adapting treatment based on response can therefore improve outcomes. So it is pretty important to offer preoperative therapy to those patients who are candidates. And so generally speaking, we consider giving preoperative treatment to anyone with a tumor that's either over 2 centimeters or has lymph node involvement. And so I think this is where a multidisciplinary conversation is pretty important, because you need to assess with your surgical colleagues, do they feel that they're a patient who potentially could have a breast conserving surgery? Are they someone who's a candidate for mastectomy? How could that potentially change given response to preoperative therapy? So usually we are having communication with our surgeons and radiation oncologists up front prior to making this decision. But generally speaking, we do tend to give systemic treatment, again, to those patients who have tumors that are over 2 centimeters or have lymph node positivity. If they're smaller than 2 centimeters and have no lymph node involvement, then we often consider taking them to surgery up front. When thinking about which systemic therapy to give in the preoperative setting, generally speaking, the two standard regimens to consider are either TCHP, so docetaxel, carboplatin with trastuzumab and pertuzumab, given every 3 weeks for 6 cycles, or to consider the ACTHP regimen. So that regimen involves giving adriamycin and Cytoxan, followed by either paclitaxel or docetaxel with trastuzumab and pertuzumab. Generally speaking, we do tend to prefer using a non-anthracycline-based regimen, given lower rates of cardiac toxicity and potential leukemia with omitting anthracycline. And so most of the time, we tend to prefer using the TCHP regimen upfront prior to surgery. In terms of how patients actually do based on response to preoperative therapy, we do know that patients who achieve a PCR have better outcomes than those who fail to achieve a PCR, with patients who achieving PCR tending to have rates of recurrence that range somewhere between 10 to 14% at most. And I think that those rates are continuing to go down as our systemic therapy has continued to improve. Generally speaking, we do know that pathologic complete response rates are higher in patients who have hormone receptor negative HER2 positive cancers relative to those patients with hormone receptor positive HER2 positive disease. And this is true regardless of regimen that's selected. So whether it is TCHP, ACTHP, or even TDM1P, again, this is consistently seen across trials. However, when you look at long-term outcomes for patients, we do see that over time, despite seeing differences in rates of PCR in these two groups, long-term outcomes are actually quite similar. So again, while we know that the hormone receptor positive, HER2 positive patients tend to have lower rates of PCR, again, long-term outcomes do seem to be fairly similar to the hormone receptor negative patients.